Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, maybe even the primary care physician, Dr. Paul Nelson Williams. We're going to be talking about the evaluation of neck pain, chronic neck pain specifically, which is a really common complaint in primary care. So, Paul, what are the three buckets of neck pain?
Well, as our listeners presumably know, neck pain is extraordinarily common. The three big buckets, as you allude to, there's mechanical neck pain, which is sort of the bread and butter. My neck just hurts, and that's probably the one you're going to see most commonly in the office. And we'll get into that in just a second. There is cervical radiculopathy, and now we have a little bit more of neurologic symptoms as part of the presentation. They may have weakness, they may have pain, though not quite as pronounced as the third thing I'm going to talk about, which is cervical myelopathy, which is the one that probably warrants a little bit more aggressive follow-up and evaluation and potentially even management. And that is where you actually have, typically in your older patients, in non-traumatic cases, this sort of bony impingement on the central spinal cord that leads to upper motor neuron signs and can ultimately be very devastating. It's almost a spectrum of presentations to worry about in terms of severity and outcomes. But we'll start with the mechanical neck pain. So the one that we see the most commonly, it's very commonly seen in the primary care office. We've all dealt with this. This is the patient who's got localized neck pain that doesn't really radiate anymore. It kind of sits in the middle of the neck. In fact, if you actually sort of poke back there, the patient says, ouch, you're probably at least in the right ballpark. The etiology and the pathophysiology, weirdly, are still not super well defined, but probably is mostly myofascial in etiology. And as such, this often gets better no matter what you do with it. It will probably get better with time. It's characterized by pain specifically, so you're not going to have neurologic deficits with this. There's not going to be weakness. There's not going to be radiation down the arm. There's not going to be upper motor neuron signs. No one's going to be mentioning any urinary symptoms with this, Matt. You can treat with NSAIDs and physical therapy, which may be necessary if it persists for a little bit. Massage can sometimes be helpful, but basically you're just kind of supporting the patients through their own natural healing process. And ideally, physical therapy might help with the ergonomics and just make sure that they position themselves in a way and move in a way that does not exacerbate the underlying structures. So that one is probably the one that we see the most and in some ways probably the easiest to manage.
Yeah, agreed. And it's reassuring. This is the one that we generally should be least worried about. For cervical radiculopathy, which is the second bucket, not as severe as myelopathy. So it's kind of in between the two. So cervical radiculopathy, it's basically with a patient who has neck pain that's going down one arm or the other, usually not both arms, because that would be weird for them to have symmetric radiculopathy. Usually it's a nerve being pinched somewhere. I think of this as being like foraminal impingement. And so it's usually more on one side than the other. And the good news for patients and what you can tell them is, listen, the natural history of this is it's going to get better over time, almost no matter what we do. I almost think of this akin to sciatica. Usually sciatica and cervical radiculopathy do not have any motor weakness along with them. It's really just the pain and maybe a little bit of mild sensory symptoms. So you can reassure the patient that this usually goes away. Our guest said he sometimes gives gabapentin for this. Personally, that's not my practice. I would be more likely to refer to physical therapy, try some NSAIDs. If they're really having trouble functioning, maybe some muscle relaxants. But again, Paul, this is the one that they aren't going to need to go to surgery. But what about cervical myelopathy, Paul? Do those patients need to go to surgery?
The idea with cervical myelopathy is to keep it from progressing. So as I mentioned earlier, myelopathy, which is not very much on my radar when I was in training. It's not something I really thought much about, I think, until I was actually in practice. But it's typically, as I mentioned, in older patients, it's arthritis and sort of bony buildup that's compressing on the spinal cord itself. So these patients will have neck pain as part of it, typically, but not always. But it's also associated with impairments in motor function and other neurologic deficits. So the patients may report that they have difficulty buttoning their buttons or managing fine motor skills. They may have the radicular symptoms down the arms. They'll have oftentimes an abnormal physical examination. So they may have weakness on exam, but they'll have a positive Hoffman's test where for those of you watching that business where you sort of flick the finger and look for the pincing of the first finger and the thumb. They may have abnormal tandem gait. They may have hyperreflexic patellar or Achilles reflexes. So their neuroexam will not be normal much of the time. And in later cases, because it's a promoter neuron disease, they may even report urinary symptoms like urinary hesitancy or just a feeling of general unsteadiness in gait, even though we're at the cervical level. So these are patients that if you suspect myelopathy, and that's really the trick is to think about it and recognize it when you see it, then you should probably be sending them for an MRI to evaluate. So it's for radiculopathy, if it persists or worsens, they have rapid regression, then an MRI is very reasonable. For myelopathy, you don't have to wait it out. Like you get the MRI and you refer them to neurosurgery. And it's not necessarily a neurosurgical emergency, but things should move along fairly briskly once you've actually identified it.
Right. Yeah. If someone comes to you in a wheelchair from this and they're not walking, they're probably not going to regain the ability to walk. He said you're really trying to prevent progression. Maybe people get a little bit better, but if people are already severely disabled, they're probably not going to be totally back to full functioning, even with a surgery. But you're just trying to prevent things from getting worse, and that's the big reason to identify this and take patients to surgery for it. So we had a lot of more details for this. This is a very kind of superficial review of what we talked about with Dr. Anthony Makula on this episode. So click on the link in the transcript if you want to see the full episode. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Oh, and I remain Dr. Paul Nelson Williams. Thank you and goodbye.